In terms of acetylcholinesterase inhibitors, while there's modest improvement and overall neuropsychiatric symptoms, the subset of agitation is not really markedly impacted by these class of drugs. This protocol was developed out of a British study that empirically treated agitated demented patients with pain medication, starting with 1 gram of acetaminophen 2 to 3 times a day. If that didn't work, they would escalate to low-dose morphine and again increase the dose of the medication for testing efficacy. We don't really use buprenorphine, so the next step for us would be pregabalin, particularly if there's a neuropathic pain. According to the Cohen-Mansfield Agitation Scale, there was a significant decline in agitation symptoms by using this pain management protocol. Again, that's using Tylenol first, morphine second, and thirdly, pregabalin in an escalating dose and not in a summative way. You could maintain the acetaminophen and then add morphine, but the study actually just switched over from one to the other. Empiric pain management reduced agitation by nearly 20%. Importantly, cognitive status did not change with the pain medication, nor did the activities of daily living. It really emphasizes that pain treatment really should be the mainstay of empiric intervention in older adults with agitation, dementia, and illness. What is the impact of antipsychotics and controlling agitation in demented states, both in terms of the short-term and long-term effects? Acute agitation with evidence that the patient is going to harm themselves or others. The American Geriatric Society advocates Haldol, either orally or intramuscularly, and you just escalate the dose every 30 to 60 minutes, doubling the dose and then reassess. Always keep in mind that you need to look for underlying medical problems that could be causing the agitation, such as urinary tract infection, metabolic disorders, hypoxia, and so forth. Here's today's polling question to consider. What is the preferred antipsychotic for maintenance therapy in patients with Lewy body dementia? A. Haloperidol. B. Risperidone. C. Quetiapine. Or D. Olanzapine. The correct answer is C. Quetiapine. Once you've controlled the agitation, you then provide a maintenance dose that is 1/2 of the initial dose twice daily. After 3 days, you attempt de-escalation with a gradual tapering dose of the antipsychotic. If it's not working to reduce agitation, then it's best to switch from Haldol to Risperidol or Quetiapine, with the caveat the Quetiapine is preferred in Lewy body dementia, Parkinsonism, and AIDS dementia. One of the questions is, can we predict the relapses of agitation and psychosis after stopping the antipsychotic? People with auditory hallucinations are refractory and are more likely to relapse than people with visual hallucinations. Overall, studies show that only 11 to 13% of patients with dementia and agitation actually benefit from long-term use. So you can use that as kind of a rule of thumb, that if you have a panel of patients that are on antipsychotics, it should only represent about 10 to 15% of the entire population that you're dealing with for agitation. An important point is that antipsychotics increase hospital-acquired pneumonia. These medications are not without risk. Also worth mentioning is the black box warning of increased stroke and heart attack due to these medications. There's a definite hazard ratio for using antipsychotics. They are associated with a higher mortality and really need to be used with great caution. Our efforts to reduce antipsychotic use is represented here in North Dakota. This study is a little old now, but it shows that there is about a 4% decline in antipsychotic use, which is not a spectacular reduction. There are some states where 5 to 10% of the nursing home population take antipsychotics, which is a more laudable goal given the multiple side effects of these antipsychotics. You can't order Haldol as needed. If you refer somebody to a nursing home from the hospital with PR and Haldol, it's not going to happen. In fact, if they are on Haldol, you have to write orders for de-escalating the dose over the next 1 to 2 weeks. There are other approaches towards treating behavioral disorders and Alzheimer's disease. Citalopram has been used for controlling agitation as anticonvulsants. There are other medications which work marginally, and others that don't work at all. You might ask, why use prazosin? There was a study linked to prazosin and being effective in traumatic brain injury. It turns out it's not so effective in brain deterioration due to Alzheimer's disease. When using the anti-epileptic drugs, you can do a trial of low-dose valproic acid. They don't always work, but sometimes they're used to reduce the frequency of agitation in the older adult with dementia. Nabanol has mixed effects. With this medication, it's sometimes not as effective as some of the randomized controlled trials. Some symptoms include changes in appetite and hyperexcitability. This leads us to the question of non-pharmacologic approaches to agitation and dementia. Pain management is effective for reducing symptoms. Long-term exercise is very valuable, as is music therapy. Some studies show that harp music live, rather than digital or CD-based harp recorded music, is effective. There's some thought or speculation that harp music improves parasympathetic nervous system tone, which is the more sedating part of the nervous system. Not effective, unfortunately, are aromatherapy and bright light therapy. This study shows the reduction in agitation with long-term exercise, according to the Neuropsychologic Inventory Score. An important point in medical management of dementing illnesses is to educate the family and caregiver. It's really important to stress with the family to have them not argue with the patient, make correcting gestures, pointing their finger at them, or saying, "Mom, you know, come on, Mom, you can remember," or to even do any type of reasoning with the older adult with dementia. These all go very circular and start to spiral downward into agitation and are very frustrating for the demented patient. We also need to educate the family on providing nonverbal communication, like smiling, even if the older adult with dementia is doing something that they don't particularly like. You always want to put on a disarming face as opposed to the frown, which may get the patient with dementia all worked up thinking, "Why are they frowning? There's something wrong here." It increases their anxiety and their agitated behavior. Finally, you want to redirect the patient with different things, like a promise to go to another place for food. These are distractors. These are all important elements for redirecting the patient. Patients with Alzheimer's live longer if their caregivers have training. Likewise, there's less caregiver distress, so it's important to take care of the caregiver in your management of the cognitively impaired patient. Here's our case study for today's topic. Mrs. Evans is an 85-year-old female resident in a long-term care facility with a 7-year history of Alzheimer's disease, AD. She's currently in the moderate to severe stage, MMSE score of 9. She presents with a 3-week history of escalating agitation, including verbal outbursts, physical resistance to care, for example, pushing caregivers during bathing, pacing, and nocturnal restlessness. Her family reports she has become increasingly withdrawn and irritable, with no clear triggers identified initially. Comorbidities include osteoarthritis of the knees and hips, hypertension, and a prior urinary tract infection, UTI, 6 months ago. She is on donepezil 10 mg daily for cognitive symptoms, with no recent changes in medications. Upon assessment using the Cohen-Mansfield Agitation Inventory, CMAI, Mrs. Evans scores 65 out of 203, indicating moderate agitation with prominent physically non-aggressive behaviors, for example, pacing and verbal agitation. The Neuropsychiatric Inventory, NPI, score is 28, highlighting irritability and anxiety. Differential diagnosis includes Underlying pain, for example, from osteoarthritis. Medical causes, UTI, constipation, hypoxia, or metabolic disturbances. Environmental factors, overstimulation or caregiver interactions. Labs and imaging rule out acute infection, negative urinalysis, electrolyte imbalances, or delirium triggers. Physical exam reveals joint tenderness, suggesting unrecognized pain as a contributor. No auditory or visual hallucinations are noted, reducing concern for primary psychosis. A multidisciplinary team, geriatrician, nurse, occupational therapist, and family, adopts a three-prong approach: functional, neurological, and behavioral, emphasizing non-pharmacologic interventions first. Non-pharmacologic interventions. Family and caregiver education. Caregivers are trained to avoid common pitfalls like arguing or correcting Mrs. E. Instead, they use redirection techniques, for example, offering snacks or changing the subject, and positive nonverbal cues, for example, smiling, gentle touch. Family members attend a session on dementia communication, reducing caregiver stress. Environmental modifications. Structured activities are introduced, including daily music therapy, live harp music sessions, 30 minutes twice daily, based on evidence favoring parasympathetic stimulation. Long-term exercise program. Gentle chair-based exercises 3 times weekly to promote physical function and reduce agitation over time. Sensory interventions. Dimmed lighting in evenings and aromatherapy, lemon balm oil, try ALD briefly, though evidence is mixed. Outcome after 2 weeks. Partial improvement in nocturnal agitation, but daytime verbal outbursts persist. Pain management protocol. An empiric trial was initiated due to suspected under-recognized pain. Step 1. Acetaminophen 1 gram orally, 2 to 3 times daily for 3 days. Evaluation. Partial response, CMAI reduced to 52, but agitation persists during mobility. Step 2. Escalate to low-dose morphine sulfate 2.5 milligrams orally every 6 hours as needed, titrated to 5 milligrams after 48 hours. Avoided buprenorphine, not commonly used. Pregabalin considered if neuropathic component suspected but not needed. Monitored for side effects. No constipation or sedation noted. Outcome at 8 weeks. Significant agitation reduction, CMAI to 38, 18% overall decline, aligning with study findings. Cognitive status, MNSE, unchanged at 9, activities of daily living, ADL, stable, with no deterioration in bathing or dressing independence. Pharmacologic interventions for acute agitation. On day 4, an acute episode of imminent self-harm, attempting to climb out of bed, prompts intervention. Haloperidol 0.5 milligrams orally administered, evaluated after 1 hour with no change, doubled to 1 milligram IM. QT interval checked, 420 milliseconds, safe. No QT prolonging drugs, for example, donepezil continued cautiously. Maintenance. Half initial dose, 0.5 milligrams, every 12 hours for 3 days. De-escalation. Tapered over 1 week, 0.25 milligrams, 12 hours for 3 days, then discontinue. Switched briefly to quetiapine 25 milligrams at bedtime if needed, preferred in Parkinsonism, though absent here, but not required post-pain control. Avoided long-term use due to risks. Adjusted hazard ratio for mortality 1.61 per 2017 MEDAL study, N equals 70, 718 AD patients. Pneumonia risk doubled. No relapse noted. Auditory hallucinations absent, reducing relapse prediction. Adjunctive therapies. Trialed low-dose valproic acid, 125 mg AM, 250 mg PM. Briefly, if anticonvulsants needed, but discontinued due to good response to pain management. Consider dronabinol, 2.5 mg nightly for nocturnal symptoms, but held as non-pharm approaches sufficed, evidence mixed, with potential for appetite changes. Outcomes and follow-up. At 12 weeks, agitation resolved, CAAI 32, NPI 12. Mrs. Evans engages more in activities, with improved sleep and reduced caregiver burden. No adverse events from interventions. Family reports higher quality of life. 6-month follow-up. Stable on donepezil and acetaminophen PRN. No antipsychotics. Referred for comprehensive geriatric assessment to optimize function. Discussion and key lessons. This case illustrates the efficacy of a structured pain management protocol in reducing agitation by addressing under-recognized physical discomfort, as supported by the BMJ 2011 cluster randomized trial, Husbo and others, which showed a 17% agitation reduction at 8 weeks without cognitive or ADL decline. Integrating non-pharmacologic approaches, for example, music therapy, per evidence of long-term benefits, and rapid antipsychotic de-escalation aligns with CNS goals to limit antipsychotic prevalence to 10 to 15% in dementia care, avoiding risks like the 1.61 mortality hazard from the 2017 MEDALS cohort study. Broader implications. Always prioritize reversible causes, such as pain or medical issues, and non-drug strategies. Educating caregivers extends patient survival, per JANA 1996, and prevents escalation. In refractory cases, consider off-label options like cannabinoids cautiously, with close monitoring. In summary, we always want to focus on the functionality of the patient, their neurologic function, their physical function, and their cognitive function. The behavioral changes that may crop up from time to time may reflect an underlying medical problem, such as urinary tract infection, metabolic disorder, hypoxia, and so forth, unresolved pain, and all these need to be assessed on a systematic routine basis when there's been a new change in behavior. Whenever possible, try to use non-pharmacologic approaches toward managing behavior. Sometimes when people have, for instance, visual hallucinations or auditory hallucinations, ask them, does it trouble you? Are you bothered by these? If they say, no, I've gotten used to it, then maybe treating with a medication is not really warranted, but again, it requires constant monitoring and feedback from both the caregivers as well as the patient themselves. Whenever possible, you want to de-escalate antipsychotics. This is particularly true in post-hospitalization, where the older adult may have been hospitalized with an episode of delirium and was given Haldol. If that's the case, there should be a systematic approach towards de-escalating the medication and trying to eliminate it entirely. Finally, treat the family and the caregiver as well as the patient. There's a lot of research on caregiver stress, leading to increased hospitalizations. If the caregiver is hospitalized, then who's going to take care of the patient? With each clinic visit, it's always good to ask the caregiver how they're doing and be aware that there's tools of assessment to evaluate caregiver stress. If you have the ability to refer to geriatrics for comprehensive geriatric assessment, this modality works. For all the studies that have been done in terms of hospital-based and clinic-based geriatric assessment, they all show improved outcomes and lower cost for the older adults. Referrals for geriatric assessment are to be encouraged. Thank you for your attention. We look forward to you continuing this online series for geriatric knowledge and skills.